PGI Sciences at Apollo Gleneagles, Calcutta. Dr. Goenka.
Thank you, sir. Am I audible?
Yes, sure.
And is my slide seen, sir?
Yes, we can see.
Okay. So good evening, everybody. Thanks to Professor Kochar, Dr. Usha Datta, Dr. Harshal and the team for asking me to be present on this meeting. It's always a pleasure to be seen and heard in your own alma mater, where I spent almost 13 to 14 years. So ever since these two gentlemen from Japan and Germany invented sphincterotomy, I think it has become a bread and butter for all of us therapeutic endoscopists. But of course, it carries risks like pancreatitis, bleeding, infections, and so on. So I have to talk only about post-ERCP bleeding, and the post-ERCP bleeding is a wide spectrum. It can be very rare in somebody's experience. It can be very frequent. It can be immediate or delayed, just like with cystogastrostomy. It can be small amount or insignificant. It can be massive, and it may be self-limiting, or it may be refractory. So what I'll do in the next 15 minutes is to talk to you about the timing, frequency, severity, risk factors, prevention, anatomy of the area, and the treatment. Now, so as I said, the post-ERCP bleeding can be either immediate or intra-procedure, usually after endoscopy, sphincterotomy, stone extraction, stenting, and this can be either in the form of a oozing or a spurting. More difficult to diagnose is delayed or post-procedure bleeding, which can happen within hours to days, and sometimes you need to take a clear history from the patient because the symptoms may not always be forthcoming about the existence of melena after the procedure. And again, this bleeding can be either occult or obscure. So there's a wide variation in the reporting of post-ERCP bleeding from 1.1% in some series to 48%, but clinically significant bleeding in a multicenter study was found in 1.1%. Fortunately for us, this bleeding is usually well controlled, and the mortality with bleeding is uncommon, though morbidity may be very significant. So endoscopically significant bleeding has been reported early cases in 10 to 12% and late cases 4.2 to 10.3%. So what is endoscopically significant bleeding? Something which obscures your vision so that you have to abort your procedure, or a bleeding which persists at the end of the procedure should be considered clinically significant. So Peter Cotton, like in other complications of post-ERCP, has classified post-ERCP bleeding into mild, moderate, and severe. Mild, which results in abortion of procedure, unplanned admission for less than 4 nights. Moderate in when there's an unplanned admission from 4 to 10 nights, severe will be more than 10 nights, ICU admission of 1 night, ICU admission of more than 1 night, need for transfusion, need for surgery, repeat endoscopy, intervention radiology, and permanent disability will differentiate moderate from severe. So I think it's very important to understand the risk factors. And I think next 3 or 4 slides are very important because we now know that most of these bleeding are preventable. And Martin Freeman has worked quite extensively on this area. And these are some of the definite risk factors, and this gives the odds ratio. So if you look at intake of anticoagulants, 4.4, platelet count less than 50,000 is the highest odds ratio of 35.3.
Dr. Goenka, your slide is not moving.
Not moving from the very beginning?
No, yeah, now we are on that particular slide. Yes.
Okay, so there seems to be a little delay. So platelet count less than 50,000 has the highest odds ratio. Cirrhosis has an odds ratio of 2. Chronic kidney disease on dialysis 1.8. Intra-procedural bleed by itself is 4.2, and low endoscopic experience can be another factor for increasing the risk. Now, there are other risk factors which may or may not increase the risk of post-ERCP bleeding. Can be pre-cut sphincterotomy, intake of NSAID, balloon sphincteroplasty, use of pure cut, and orientation of sphincterotomy. So I think the next 2 or 3 slides are very important for the youngsters. And I think this is not only important to reduce the bleeding, but also medico-legally very important, because now there are set guidelines by the European Association for managing the antithrombotics before ERCP. And one must not deviate from this usually. So you have to look at 3 factors. One, what is the drug we are talking about, say aspirin or P2Y12 inhibitors like clopidogrel and so on. What is the indication for giving this drug? whether there's a low-risk indication or high-risk indication, and what are the procedure we're talking about at ERCP. Low-risk procedure will be biliary stenting without sphincterotomy or cholangioscopy, whereas a high-risk procedure will be ERCP with sphincterotomy or ERCP with sphincteroplasty or ampulectomy. Now, for aspirin, for whatever indication it's never started, for low-risk procedure, you can continue aspirin. When you're doing an ampulectomy, it is advised that you stop aspirin 5 days before the procedure and start 2 to 3 days after the procedure. For P2Y12 inhibitors like clopidogrel and so on, if there is a low-risk indication, for low-risk procedure, you can continue the therapy with these drugs, whereas for high-risk procedure, you must stop these drugs 5 days before the procedure. You can continue aspirin if the patient is already prescribed and restart these drugs 1 to 2 days after the procedure. However, if these drugs have been started for high-risk indications like drug-eluting stent or bare metal stent, while you can continue these for low-risk procedure, for high-risk procedure, particularly if the drug-eluting stent has been placed less than 12 months or bare metal stent less than 1 month, you must discuss with the cardiologist for the risk involved. Let's move to the anticoagulants, warfarin. Now again, whether it's a low-risk indication or a high-risk indication, for low-risk indication, for low-risk procedure, you can continue warfarin if your INR is within the therapeutic range. But for high-risk procedure, for low-risk indication, you stop warfarin 5 days before the procedure. If the indication is high risk, then when you stop warfarin, you start in next 1 or 2 days, low molecular weight heparin, which should be stopped on the day of the procedure only. Nowadays, we are using a lot of direct oral anticoagulation or DOAC, and this for low-risk procedure should be omitted on the day of the procedure, but for high-risk procedure should be omitted more than 2 days before the procedure. So we talked about the various risk factors. Now, a little bit about the arteries around the duodenal papilla. So we know that the duodenal papilla is supplied by superior pancreaticoduodenal artery and the inferior pancreaticoduodenal artery. Each divides into anterior and the posterior branch, and there's a communicating branch between them. And all these can be supplying the papilla. Now, this is some of the cast, and this is how the anatomy looks like. Now, fortunately for us, if you look at the clock of the papilla, 10 to 11 o'clock, which is a usual area of biliary sphincterotomy, has less of the vessels. So this diameter of the vessel and the number of these dots indicates the vascularity of that area. Fortunately for us, 10 to 11 o'clock is usually a low vascular areas. Now let me now move to the treatment part. I think the treatment basic principle is the same as what was discussed during cystogastrostomy by Dr. Rai very nicely. So when do we need the treatment? Immediately if it's endoscopically significant, and delayed if it's clinically significant. And how do we do it? We must monitor resuscitation, endotherapy, angioembolization, and rarely we require surgery. So in my practice, the first thing which I do, and I find it very, very successful, is do a balloon tamponade. So this is a patient you can see after sphincterotomy, there's a bleed. I would do a balloon tamponade and keep it for about 4 to 5 minutes, which is the clotting time for bleeding time for most of these patients. And invariably, in about 90% of the patients, the bleeding will stop. So for me, the first procedure is balloon tamponade before we come out. Now, if that fails, then you can go for injection therapy. We usually use epinephrine, 1 in 10,000, apply at the apex of the papilla because that's the side which bleeds. It's not the sides or the bottom which bleeds, it's the apex which bleeds. And you can inject any amount required, but you must be cautious to avoid pancreatic duct opening as much as possible. And the success rate is again 96 to 100%. Now, if that fails, then you can use one of the thermal coagulation, HETA-Pro, bipolar, APC has also been used. People have recently used coag forceps also, though it may be technically more demanding. But again, when you apply all these, you must avoid pancreatic duct opening. If all these fails, you can do a mechanical method, which is hemoclips. But let me tell you, it is not easy to apply hemoclip with a side viewing scope. You may try it because manipulation is very difficult. And one may try a cap-fitted forward viewing endoscope to apply hemoclips. If all these fails, and this is one of our patients which we reported in GI endoscopy, that this patient, as soon as I took out a plastic stent, which was already placed, and this was an unrecognized case of portal biliopathy, the patient had massive bleeding, almost like arterial spurter. But as soon as we put a metal stent, the bleeding stopped, just like the case which was shown by Dr. Rai in cystogastrostomy. So I think this is a very, very interesting and appropriate use of a fully covered metal stent to stop desperate bleeding in the procedure. Now, this is another patient, if the video runs. Patient had multiple stones, both intrahepatic stones as well as bile duct stones. And while I was doing a balloon clearance of these stones, the patient had massive bleeding, as you'll see just now. So as the balloon is coming out, there was a massive bleeding. And in this case, I did not go for any of the other procedures, and I immediately put a metal stent in this case. You can see how the bleeding, spurting is taking place, and metal stent stopped the bleeding immediately. So this is the algorithm: balloon tamponade, injection therapy, thermal coagulation, hemoclips, self-expanding metal stent, and rarely you may require angioembolization surgery. Hemostatic powder and fibrin glue have been used on anecdotal cases, but do not have a real place in the algorithm. So this patient is one of the 2 or 3 cases in the last 4 to 5 years where we had to ask our intervention radiologist to go in and then put coils, as was shown nicely during the angio talk a few minutes back. Now, 1 or 2 words about, so this is how the ESG guideline says that for persistent or delayed post-sphincterotomy bleeding, you should inject epinephrine with or without thermal and mechanical means, and self-expandable metal stent has a role. I'll just spend 2 minutes on delayed bleeding, and the delayed bleeding algorithm is just like any ulcer bleed. For clean ulcer or pigment spot, no endotherapy. For adrenal clot, usually I would remove the clot and find out what is the base. If it's clean, no endotherapy. If it's oozing or visible vessel, go for endotherapy. Of course, if there's a visible vessel or oozing or spurting, then we'll go for endotherapy. One of our very old patients, I think about 16 years back, as you can see, and there was a large clot which was removed. And after removing the clot, I found a diffuse ooze from the side of the papilla, which was managed by, if I remember, by electrocoagulation. So first I cleaned that area. I think I injected adrenaline at that area. And then you can see I'm injecting adrenaline. Let me tell you that sometimes taking out the needle, even from the side wing scope, may be difficult. So you may have to cut the part of the catheter to make the needle come out through the ERCP elevator. So here I injected adrenaline all around and then applied coagulation, and that stopped the bleeding. The only risk is that there's a slightly increased risk of pancreatitis after injection in this way. So amount may vary anything between 1 ml to 15 to 20 ml. And only injection I usually will not do, and we will combine with some other mechanism, which can be either mechanical methods or, as was done in this case, by using gold probe. Let me skip the video, but you have to put a little bit of pressure. So the take-home message is that most of the bleeding can be controlled, and one should not be worried about that. So prevalence of post-ERCP bleeding is variable. Risk factors are almost well identified. Preventive measures can reduce the risk in majority of cases. Immediate bleed, one should go for a stepwise approach, and for delayed bleed, one must diagnose by a careful observation and treat as per the findings. So as I said, while post-ERCP bleeding is not a very uncommon recurrence, unlike pancreatitis, usually it's within the control of the endoscopist, and you can prevent significant morbidity and mortality. Thank you very much.
Thank you, Dr. Goenka, for your excellent talk and good illustration of cases. My question is that how frequently you needed surgical intervention for post-endoscopic, post-ERCP bleeding?
In the last 15 years, none. I would say not even one case has gone for surgical thing. We had 2 or 3 cases we have taken angioembolization. And I only remember one patient in the last 15 years who succumbed to post-ERCP bleeding. We have a moderate amount of volume of ERCP, and I think most of them can be controlled by endoscopy. So only 2 or 3 cases required radiological help, and none required surgical help. We lost only one patient because of the post-ERCP.
And secondly, I mean, you demonstrated bleeding in relation to stone extraction. Sometimes we have seen patients, I am a GI surgeon per se, we have encountered patients who had periampullary or ampullary malignancy or pancreatic head malignancy, they'll end up having post-ERCP bleed. And sometimes these bleeds are massive, and in 1 or 2 patients, we need to do emergency resections also. So what is your experience on bleeding in context with the malignancy?
I would say that the bleeding, when you're doing a sphincterotomy in an ampullary tumor, there may be a little bit of ooze, but most of the time, in my experience, this is not a major bleed. So major bleed can happen with ampulectomy, and I still vividly remember Nagi is here. We were in London possibly for a meeting, and there was a transmission going on from AIG, and there was a massive bleeding after ampulectomy. So bleeding do happen, but as I said, most of them are under control of the endoscopist. And fortunately for us, we have not required help from surgeons like you in our setup. I did lose one patient 15 years back when I had gone for a conference just after doing an ERCP, and we lost that case. So other than that, I don't remember any patient which we have lost because of post-ERCP bleed.
So I think we can have questions from the floor.
Yeah, thank you. Dr. Goenka, it was excellent. Once you resort to the SCMS placement for a varicose bleed, this thing like you put in a case of biliopathy bleed, which stent you would choose?
So these are all covered stent. You can use fully covered stent because this is usually only a temporary method. A couple of cases we had to resort to portal hypertension surgery after we have controlled the bleeding in portal biliopathy. So invariably, these stents are fully covered removable stent. As you all know that the fully covered removable stent, there is a theoretical risk of cholecystitis and a slightly increased risk of pancreatitis, but in our experience, that's not a huge issue. And we don't keep these stents for too long. We would usually remove them in about 2 to 3 months' time.
So what are the intra-procedural factors that can predict the delayed bleed?
I would say the end point is very important. You should be very comfortable at the end point. Don't leave a slight ooze going on at the end of the procedure. Spend some time when you think you have completed the procedure. Spend some time, see whether there's some ooze is going on, and also look at the blood pressure. You must maintain the blood pressure not too high. I have often seen that during the procedure also, if the blood pressure goes high and there's some ooze, and I ask my anesthetist to reduce the blood pressure by whatever means they can, the bleeding stops. So I think maintaining blood pressure at the end of the procedure, achieving a full hemostasis, and also taking care of the coagulopathy in the posterior period will be important.
Dr. Goenka, any comment on needle knife access leading to bleeding immediate or delayed?
So I would say that usually it depends on whether your needle knife is successful or you're not successful. If you are successful, by the time you complete the procedure, you put a stent, everything settles down. If it is unsuccessful, I would spend time to stop the bleeding. In general, I don't have the data to say that, but then, as I said, some of the studies have shown that the needle knife increases the risk of bleeding. But this is not a very consistent finding. But if I'm using a needle knife, I will ensure at the end of the procedure that either I'm successful or I achieve a complete hemostasis. I usually not inject or do, even if I'm not successful, I would not usually inject too much of amount or use thermal coagulation because that will reduce my risk of success after 48 hours.
Well, thank you very much, Dr. Goenka, for an excellent talk. We now go on to the next talk in this session, and that is biliary stent-related complications. All kinds of complications can occur after placement of a biliary stent, be it plastic or metal. And how do we tackle that? To elaborate on that, we have Dr. Nageshwar Reddy from, you all know him as director and everything of all Asian Institute of Gastroenterology, Hyderabad. And he has spared time to talk to you all on this important topic. Nageshwar.
You need to unmute, Nagi.
I think you are not audible.
So thank
Dr.
you.
Reddy, you are not audible.
Now I'm audible. Now is it okay?
Yeah, you are audible.
Thank you.
Yeah, it's okay.
Thank you, Rakesh. In fact, I would have loved to be there physically, but we are actually doing one international transmission. So that's the reason I couldn't be there. Maybe next time. And then like to thank Usha for this very kind invitation to talk on a subject which I think is not often talked on. I think we just heard Mahesh give a brilliant talk on this area, but this is stents are something that put in and forget about it. So let me discuss a little on this subject. In fact, 1979, Nip Sohendra did the first stenting. It was actually a very thin stent for a patient with malignant obstructive jaundice. And the indications, the techniques and technology have completely changed. In fact, they've expanded. Plastic stents, which we used to put often, are given away to self-expanding metal stents, uncovered to completely covered metal stents. So the field is dramatically changing, and so too are associated complications and so on. So if you look at complications of biliary stents, those which occur very early, usually within 48 hours of stenting, are about 5% in this bleeding, perforation, and migration. Late ones are usually in form of dysfunction or very rarely with a completely covered stent, like Mahesh mentioned, cholecystitis. This invariably occur in almost all the stents, so actually the percentage is extremely high. So let's look at these two phenomena, early and late. So if you look at the various complications of stenting, occlusion is extremely high with plastic stents. Invariably after 3 months, 90% of this stent should get blocked. Less with self-expanding metal stents, especially with covered stents, but with uncovered stents, tumor ingrowth can cause this. Migration, again, very high with plastic stents, but with completely covered stents, you can see it. Cholecystitis, more with SEMS. Rarely pancreatitis perforations could be part of ERCP procedure also, but could occur with this. So let's first look at the stent migration, plastic stents. If you look at plastic stent migrations, they can migrate proximally or distally. They can migrate into normal duct or migrate above a stricture. For distal migration can occur with or without perforation. So this is the general classification of biliary stent, plastic stent migration. Now, when these stents are migrated, extraction of the stent, proximal extraction can be done by indirect traction, direct traction, or cannulation retrieval, and I show you these examples. Whereas if it migrates outside, we use a snare forceps to take it out. Also, you have to often close a perforation which occurs. Increasingly, cholangioscopy is being used in these difficult cases. So let me illustrate this by showing you that if the stent is migrated inside, especially when a normal duct is not so easy to remove, it's quite easy to remove it, but with a stricture, it becomes more difficult. There are several techniques. Indirect traction is to pass a guide wire above, inflate a balloon, and try to take out the stent. I think the recent workshop from Mahesh's unit is done by TSC. If it is also sometimes possible to use a snare, basket, or a forceps to catch it below and do a direct traction. Or sometimes if you can't, you can pass a guide wire inside the stent, put a balloon and get it out. Very often we use this Sohendra stent retriever. Once you have a guide wire inside the stent, you can screw this retriever inside the stent and take it out. So these are the various techniques that is used, but increasingly now we are starting to use cholangioscopy. And this is an example of a cholangioscopy being used for a broken stent. The stent actually got broken. And you can see that with cholangioscopy, we now have a SpyMax basket forceps, which is quite strong, in fact, much stronger than the older one. And this stent can be now got out using this. Sometimes we can use a more stronger cholangioscopy. This is the direct cholangioscopy being used in a patient. One of our patients, the stent migrated, we couldn't get it out. We're actually using a cholangioscope with a basket. And you can see that we have been able to catch hold of the stent, and the stent can then be taken out using this technique. Sometimes the stent, for example, a stent which is migrated down, very difficult to take it out if it's an uncovered stent. We use an APC with a cutting power 100, and then we can actually cut this stent completely through. Now, let's come to cholangitis, because this is a very common problem after stenting. And in general, cholangitis post-stenting is divided into two. Immediate post-endoscopic cholangitis, which occurs by definition within 72 hours, and delayed, which is due to stent malfunction, which occurs after 1 month. And you can see examples here. of cholangitis with a plastic stent. This is just within 72 hours, the patient got infected. And with a metal stent, you can see how this can produce severe septicemia and produce very serious consequences. The incidence depends upon the type of obstruction, the type of stent, the number of stents, and the technique of stenting also. In general, for hilar strictures, it's estimated that between up to 21%, sometimes 50% of the cases can get infected with cholangitis, especially dealing with type 4. That's the reason why I'm extremely careful. And even now, in our unit, the type 4 block, I would like to do it myself and do several methods to prevent putting in a guide wire, putting in a catheter before, aspirating out, and then putting in a stent eventually. In general, cholangitis is higher with plastic stents compared with metal stents, and this has been shown in several studies. Again, there's evidence that putting in a bilateral stent causes less cholangitis than a unilateral stent, especially in type 3 or type 4 tumors. The other things that increase the cholangitis is age, immunosuppression, and of course, in patients with PSC. But incomplete drainage is extremely important. We now know that we have to drain 50% of the liver, otherwise cholangitis can occur. And this is a very old but very important study which came from Canada. And you can see that what they found is that if you opacify both lobes and drain only one lobe, incidence of cholangitis and survival is extremely high. Cholangitis, very low survival. So be careful, don't inject contrast when you're stenting unless you're sure you can stent that segment. One of the things that we always do now, again from experience, we learn that even if the patient doesn't have cholangitis, we do a deep cannulation and take the bile for culture. And we find that this culture tells us what antibiotics if the patient doesn't have cholangitis. Because bile culture are often positive and cultures can be negative in this situation. So always take bile for culture in the stent. Now coming to the later complications, the most important complication is stent dysfunction. This can occur because of clogging of stent, delayed migration, tissue growth, and so on. And this is an example of a plastic stent, which after 3 months invariably gets clogged. And of course, present as cholangitis or obstructive jaundice. You put in a metal stent, you're very happy, free flow of bile, but within 5 to 6 months, this is what will happen. The stent gets clogged. This blockage could be due to a variety of reasons. It could be tumor ingrowth, tumor overgrowth, food debris, sludge and stones, blood clots, or even tissue hyperplasia and tumor compression. All of this can block the stent. And these are examples of food which causes obstruction, overgrowth of tumor, and sometimes the stent itself impinges against the other wall to produce obstruction. And this is an example of a hyperplastic tissue. You know, stent is blocked. The block is hyperplastic tissue which has grown into the stent. So between 6 to 12 months, most uncovered stents get blocked. To prevent this, there's some evidence that if you actually have an anti-reflex silicone membrane like this, decrease it, but still not clear. But once the stent is occluded, there are several techniques, especially with a metal stent. Plastic stent we change. Metal stent we can use a balloon like this to completely clear the stent. But what we found is that in many of the cases, one has to decide what is the cause of occlusion. For fully covered stent, you can replace it, but uncovered stent, you can either declog with a balloon, put in plastic stents or SEMs. And there is evidence that cholangioscopy may actually decide which technique you use. Again, this is a patient who came with occlusion, and we have a spike cholangioscopy being done. And when the spike cholangioscopy is done, as you pull back the cholangioscope, you can see clearly it's a tumor hyperplasia that is clogging of stent. People tell me, isn't it too expensive to use cholangioscope for this? No, if you actually look at what happens. Now, in this patient, then, we know that radiofrequency ablation, in ablating the tumor, is the best technique to deal with this patient. And there's evidence that the RFA in this group of patients is more successful than other techniques. If the stent occlusion is because of tumors, you don't have RFA facility, then of course you can put in multiple stents in these patients. And this is a study which looked at 3 modalities. If you have a patient with obstructed stems, putting in a stent, putting in a plastic stent, or balloon cleaning, which is better? And there's clearly evidence that putting in a SEMS and long-term in this patient is better in terms of reintervention, in terms of survival. So again, mentally we think if a stent the SEMS is blocked, put in a plastic stent is cheaper. On long term, it is evidence to show what is the cause of obstruction. Again, another paradoxical thing. If you have a blocked SEMS, should we use an uncovered stent or a completely covered stent to deblock it? This study has clearly shown that not covered but uncovered SEMS is better in terms of stent occlusion, stent patency, survival, and so on. So if you have a blocked SEMS, put an uncovered SEMS to deblock it. Of course, conventional SEMS gets blocked for a variety of reasons. It can be tissue hyperplasia, it can be tumor overgrowth, unnecessary part of the stent, and biliary reflux can occur using blockage. So to overcome this, there are now stent modifications, and this is a specialized stent called the Moon stent, which can be put specifically in this situation, decrease the blockage rates. There's another important thing that I'd like to bring your attention to. This is very common in our country. Stents have been put in, the patient has not been instructed, the patient forgets. He comes back after 2 or 3 years, and then you'll find the so-called stone lollipops. Around the stent, stones have formed. Very difficult to treat in these cases. You can't sometimes remove the stent because the whole stent is encased with stone. You have to do an extracorporeal shock with the Tutsi and then remove the stone and the stent. So this can occur. Similarly, the other thing sometimes you've seen, and this is again that Mahesh was discussing, when you're removing a stent in a portal biliopathy, massive bleeds can occur, and sometimes the patient goes into shock immediately. In this type of situation, continue to remove the plastic stents and immediately replace the plastic stent with a completely covered self-expanding metal stent, and the bleed stops quite dramatically. Then, of course, a solution that has to be done in an acute way. And finally, you can have stents which are migrated, and this is an example of a plastic stent migrated and gone and produced perforation in the opposite wall of the tip. Very often, this can be treated conservatively, but if the hole is large and associated infection, in these cases, they've had to use an OTSC clip, over the scope clip, to actually close these perforations. So, in conclusion, there are several complications associated with biliary stent. Early complications occur in 5% of the cases. Late complications can occur almost in 2/3 of the patients. Most of these complications are in form of migration, occlusions, or infections. The most dangerous complications are infections, acute cholangitis within 72 hours, or delayed cholangitis because of acute stents. All these can be managed endoscopically, and in majority of these patients, they cause morbidity but not morbidity. Thank you very much.
Yeah, thank you, Dr. Reddy, for a nice talk and a good illustration of cases. So with this, I will open the topic for discussion. Any questions from the floor?
Good evening, sir. Sir, you just showed a video of EHPO with PCC patient had a bleeding. So during ERCP in these patients, how to differentiate between an intracolloidal varix and a stone on cholangiopathy?
So this is a very good question. Normally, when we have an extrahepatic biliary obstruction with portal biliopathy and you have to do an ERCP in these patients, one of the things that I always do is to just give a shot of terlipressin just before the procedure to decrease the pressure, whether you have intracolloidal varices or not. Now, when you inject contrast, you find filling defects, which are sometimes very difficult to differentiate stones from varices. So what we would do in this patient is just actually change the head end of the patient, either raise the head end up or down. If they're floating, or if you inject contrast, if they're floating, then obviously they're caliculi and not varices. I always use a soft balloon. If I haven't put in a stent, I put a soft balloon to try and drag into the balloon. What happens is you compress the varix, you don't actually injure it. But if you use a basket in this case, the chance of injury is more. If you use a balloon and pull the stone down without checking whether this filling defect is compressive or not, the chance of producing injury again is not. So what you should do is first put the patient, give the patient terlipressin. After you cannulate, if you are doubtful the stone is not floating, then take a balloon, stone extraction balloon, and without trying to extract the stone, just see with a balloon which is inflated whether this filling defect is getting occluded, collapsed or not. So these are the two things. Don't use a basket unless you're sure. Now in rare cases, in fact, we published this in GI endoscopy. We are used colonoscopy to visualize if you're not very sure whether you're dealing where a stone and so on during the therapy. This is usually patients in one of the therapy in laser therapy to break the stones completely and so on. If you have varices and stones and if you have to get them out, might be put in a completely covered stent in these patients. It's very safe. You can do all your therapy, bring out stones and all, and after 3 months, come and get out the stent. And what happens is we have found that this stent actually not only compresses the composes the varix. It's very safe to pull out the stent, and these intracolloidal varices have completely disappeared. So these are the various techniques. I hope that answers your question.
Any other question? We had once with the first generation of JAG wire, just at cannulation, we had bleeding from the intraductal varices, which needed to be controlled with terlipressin. In fact, those days, octreotide was the thing available. It's more than 20 years ago. We could control it, and yes, even with just a guide wire.
Yeah. So guide wires, those our younger days, Rakesh, guide wires used to be hard guide wires. We never had this hydrophilic guide wires. So now I think with hydrophilic guide wire, this is less likely. But I think terlipressin and also putting in a balloon, inflated balloon, not the stone extraction balloon. Actually, in these cases, we use the balloons which you normally use for dilatation, like pyloric dilatation balloons. CRE balloon. Put in a CRE balloon and you have to keep it on for at least 3 to 4 minutes, not short period. Sometimes go and drink a cup of tea and come back, and then the bleed will have stopped.
So in patients with hilar block, is it your routine practice to drain both the lobes, or I mean, you prefer to drain the future liver remnant first and then see if there is cholangitis, drain the opposite lobe? Because as surgeons, we always have a preference of future liver remnant drainage.
So first of all, hilar, we are extremely careful. All our patients with hilar tumors go to a multidisciplinary report where surgeons and endoscopists are there and interventional radiologists. Invariably, the surgeons don't want us to do anything. They want to operate on this case. They don't want to touch. But if you look at the literature, the Japanese literature, they say that if you can get the bilirubin to 3 milligrams or less, better surgical result. Our surgeons say doesn't matter, even if 10 milligrams, they don't want us to touch, because what they found, at least in Indian situation, the infection rates are so high that once we go in, whatever we do, they have a lot of post-operative. So first we decide whether it's a surgical or not. If it is a non-surgical, mostly it's palliation. We always do an MRCP. Without an MRCP, we never touch a hilar case. An MRCP. And MRCP, one of the mistakes that as gastroenterologists we do is we look at MRCP picture of reconstructed picture, which is not right. The reconstructed picture gives a very wrong view of whether it's type 2, type 3, or type 4. What we have to do is the coronal sections and trace the ducts from the coronal sections. And then you'll actually make it very clearly which are the ducts which are, for example, when the left duct and the right duct are actually draining together, which is often an anomaly. We think that these patients actually have type 3B, but it's actually type 3A. So we have to get a good anatomy. Once we get a good anatomy, we decide that the non-atrophic lobe has to be drained. Our aim is to drain at least 50% of the liver. So we get a good MRCP. We sometimes discuss with our radiologists what are the ducts to be drained, and then endoscopically we'll target and drain. Invariably, we have to at least drain not only 50% liver, at least 2 of the segments before we achieve this 50%. Of course, we never go to the atrophic side because we'll produce infection and problems.
Good evening, sir. Sir, are the concepts and methods of stent blocks same for pancreatic stents also, sir?
Yeah, so pancreatic stents are different. First of all, we don't use metal stents so much, except the bumpy stents. We don't use metal stents so much in the pancreatic endotherapy. Pancreatic stents, the concepts are different. First of all, most often you're stenting for benign pancreatic strictures. So we dilate and put multiple stents. Single stents are not common. So even if the stent gets blocked, it's draining in a wick effect around the stent. So stent blockage giving rise to problems in pancreatic stent is not very high. Second, we always do a programmed stent exchange. That is call after 3 months or 6 months to increase the stent number or pull off the stents. This is the thing. And for some reason, even if the pancreatic, if you put up a single pancreatic stent, it gets blocked. Pancreatic infections are very, very low. We don't know the reasons. Why, unlike biliary system, the pancreatic ductal system doesn't get infected. We don't have pancreatic abscess. This is very low. So infection is very low. Migration rates are also much less compared with biliary because of the vertical and horizontal position of the pancreatic ducts. So complications of pancreatic ductal stenting is a little different. It's more often pancreatitis that you can produce or a peri-stent stricture that can occur if you use a metal stent, less often infection or migration.
So Nagi, only comment was that internal migration of pancreatic stent is a challenge sometimes.
Yeah, so that's a very important point Mahesh has made. If the pancreatic stent goes in internally, so how do you avoid that? Now, how we avoid it that we have stopped using straight stents for pancreas. We always use a single pigtail stent. The single pigtail in the duodenum, the internal part is going in. And if you're doing it for a prophylactic pancreatic stenting, for example, not for a stricture, then invariably we cut the inner flap out because it's the inner flap which creates this tendency for migration inside. So cut off the inner flap. And then when you use a single pigtail, the chances, because once the pancreatic stents get migrated inside, it's a nightmare, and also it's a potential lawsuit for the patient.
Well, thank you, Nagi, and I must thank all the three speakers for very practical tips for these ERCP related problems, which all of us face virtually every day.